Chapter 36, Hypertension. Hypertension is one of the major modifiable risk factors to prevent cardiovascular disease. As the blood pressure increases, so does the risk of myocardial infarctions, heart failure, strokes, renal disease, and retinopathy. It affects up to 46% of adults in the United States, with heart disease usually associated with hypertension, leading to 23.7% of deaths across the country. The American College of Cardiology Foundation and the American Heart Association say that hypertension management has target goals based on the patient's age and other comorbidities. These are evidence-based guidelines for the prevention, detection, evaluation, and management of high blood pressure within adults. When dealing with hypertension, promoting health equity is also a major consideration. Though it affects all ethnicities, there are three factors that account for decreasing its prevalence. Those born outside of the United States, do not speak English, or limited time living within the United States. African Americans also show a higher prevalence for the condition. They're also more resistant to hypertension. It develops at a younger age, affects females more than males, and there's more nocturnal, non-dipping blood pressures, more end organ damage, and a higher death rate. In the case of the Hispanic population, they are less likely to receive treatment and have a lower rate of awareness, treatment, and control of their blood pressures. There are also major gender differences. Generally speaking, for men, it's more common before middle age, whereas for females, it increases 2 to 3 times with oral contraceptive use. Preeclampsia could possibly be an early sign and is more common after menopause, as it's harder to control with elderly. Blood pressure is just a measure of the force exerted by blood against the walls of blood vessels, and it involves both systemic factors as well as peripheral vascular effects. And it's important to maintain tissue perfusion during activity and rest, as that blood pressure plays a very key role in getting oxygenated blood where it needs to be. And that function of cardiac output is the systemic vascular resistance. And a good equation to measure that cardiac output is stroke volume times heart rate, meaning for the volume of blood moved with one contraction of the heart, one stroke volume, times the heart rate, the number of beats per minute, would equal your cardiac output. From figure 32-1 from the textbook, these are the factors influencing blood pressure, and showing how hypertension develops when one or more of the blood pressure regulating mechanisms are defective. Regulation of blood pressure involves the nervous system, cardiovascular system, as well as the endothelial, renal, and endocrine functions. The sympathetic nervous system works on activating the heart rate and increasing cardiac contractility within seconds when needed. It also combines with vasoconstriction and renin release to increase cardiac output as well as systemic vascular resistance. On the other hand, the peripheral nervous system works to decrease the heart rate, working through the vagus nerve, and in this case, when activated, cardiac output is decreased. A good way to think about that is the sympathetic and parasympathetic nervous system are constantly working in a tug of war. Both are active at the same time. With the sympathetic nervous systems activated, it pulls the heart rate up. If the sympathetic nervous system is inhibited, it allows the peripheral nervous system to pull it down. On the opposite end of that, if the peripheral nervous system is stimulated, such as vagus nerve stimulation, it pulls the heart rate down. But at the same time, if you block that peripheral nervous system, the sympathetic nervous system is unable to pull it up. It's constant tug of war, where an action on one results in a change in the cardiac output. Within the sympathetic nervous system are baroreceptors that sense a decreased blood pressure and send a message to the vasomotor center within the brainstem, leading to efferent nerves and cardiac and vascular smooth muscle cells. Norepinephrine is also released from this sympathetic nervous system nerve endings, activating receptors within the SA node, myocardium, and vascular smooth muscle. Without going too deep, the sympathetic nervous system receptors affecting blood pressure can have a wide range of effects, everything from vasoconstriction, increased contractility, inhibiting the release of norepinephrine, again, increasing contractility and conduction, along with renin secretion in the kidneys, and finally vasodilation. Within the sympathetic vasomotor center, this is activated during times of stress, pain, and exercise to increase cardiac output and blood pressure. The transient decreases in the blood pressure leads to sympathetic nervous system stimulation, leading to peripheral vasoconstriction and increased venous return. These baroreceptors play a vital role in maintaining the blood pressure and are sensitive to stretch. Increasing stretch sends inhibitory impulses to the vasomotor center to decrease heart rate. This decreased force of contraction and vasodilation within the peripheral arterioles. Decreased stretch, on the other hand, decreased blood pressure, results in sympathetic nervous system stimulation, leading to peripheral arterial constriction and an increased heart rate. Increased contractility. While long-standing hypertension, the baroreceptors adjust to that increased blood pressure and begin recognizing it as normal. Other factors affecting the blood pressure are the vascular endothelium. This is essential to the regulation of substances such as vasodilation and nitric oxide, or vasoconstriction within the endothelium. Smoking and diabetes also have a major effect on that vascular endothelium and reduce the function, leading to increased risk for cardiovascular disease. Within the renal system, there is the control sodium excretion and extracellular fluid. The increased sodium results in increased H2O, which leads to increased extracellular fluid. This in turn leads to increased venous return and stroke volume, leading to increased cardiac output and blood pressure. The more fluid involved, the higher the pressure. The renal system also plays a major role within this. Prostaglandins from the renal medulla leads to systemic vasodilation, decreased stroke volume, and blood pressure. Also, the heart cells themselves have a natriuretic peptides, ANP and BNP. They oppose antidiuretic hormone and aldosterone and lead to natriuresis and diuresis, which in turn leads to decreased blood volume and BP. Within the endocrine system, epinephrine and norepinephrine from the adrenal medulla. These work to increase the heart rate and contractility, leading to increased cardiac output. Aldosterone from the adrenal cortex and antidiuretic hormone from the posterior pituitary also play a major role. For our first audience response question, the nurse determines that the patient has stage 2 hypertension when the patient's average blood pressure is A. 150 over 96, B. 155 over 88, C. 172 over 92, D. 160 over 110, or E. 182 over 106. And your textbook decided to play a little sneaky on you, and the answer is all of them, A, B, C, D, and E. This is because stage 2 hypertension is diagnosed when systolic blood pressure is greater than 140, or a diastolic blood pressure is greater than 90. For primary hypertension, this is also called essential or idiopathic hypertension. It's elevated blood pressure with no known cause, and is accountable for 90 to 95% of all cases. Many contributing factors include altered endothelial function, increased sympathetic nervous system activity, increased sodium intake, overproduction of sodium-retaining hormones, overweight, obesity, diabetes, tobacco, and excess alcohol. On the other side of that is secondary hypertension. This is elevated blood pressure with a specific cause or sudden development, and is accountable for 5 to 10% of all cases. The clinical findings relate to the underlying cause, such as cirrhosis of the liver, aortic problems, drug-related issues, endocrine, neurologic, or renal problems, and pregnancy-induced or sleep apnea even. The treatment is aimed at removing or treating that underlying cause, obviously. The pathophysiology is increased cardiac output or systemic vascular resistance, resulting in increased blood pressure. The risk factors for primary hypertension contribute to further progression and consequences. It is often a very slow progressing condition where they may be completely asymptomatic until significant organ damage is done, and then we begin to see symptoms after the disease has progressed for a long time. There are many risk factors for primary hypertension. Age, family history, alcohol use, obesity, tobacco use, diabetes, a sedentary lifestyle, elevated serum lipids, excess dietary sodium, socioeconomic status, because unfortunately the cheaper foods are also the ones highest in salt, highest in fat, and most contributing to this condition. In our first case study, CS is a 40-year-old male who attends a community health screening. He states that he has not seen a healthcare provider in a really long time. He is a truck driver who eats mainly fast food while on the road. He smokes a pack of cigarettes a day just for something to do during the long hours of driving and to keep him calm. CS is 5'9" and weighs 230 pounds. His blood pressure is 182 over 104, heart rate 90, respirations 24, and a temperature of 97 degrees Fahrenheit. What risk factors for hypertension does CS have? And there's a lot here: obesity, tobacco use, stress, gender, excess dietary sodium, and a sedentary lifestyle. For our next audience response question, while performing blood pressure screenings at a health fair, the nurse counsels which person is having the greatest risk for developing hypertension. Would that be A, a 56-year-old man whose father died at age 62 from a stroke? B, a 30-year-old female advertising agent who is unmarried and lives alone? C, a 68-year-old man who uses herbal remedies to treat his enlarged prostate gland? Or D, a 43-year-old man who travels extensively with his job and exercises only on weekends? And that answer, unfortunately, is A, a 56-year-old man whose father died at age 62 from a stroke. A history of a close blood relative, like father, with hypertension is associated with an increased risk for developing hypertension. Atherosclerosis is the most common cause of cerebrovascular disease, and hypertension is a major risk factor for developing cerebroatherosclerosis and stroke. The genetic link, it's different sets of genes that regulate blood pressure at different times. And children and siblings of persons with hypertension should be screened and strongly advised to adopt healthy lifestyles to reduce their risk of hypertension. Water and sodium retention also plays a pivotal role. Only 1 in 3 people who consume high sodium diet develop hypertension, and the effect of sodium on blood pressure has a strong genetic component as well. Those salt sensitive with increased blood pressure versus salt resistant who show little changes to salt intakes. Figure 32-2 from the textbook shows the proposed link among salt intake, blood pressure, and changes within the heart. High dietary salt intake exerts hypertrophic effects on the left and potentially also the right ventricles. An altered renin-angiotensin-aldosterone mechanism could also be at play, and this results in increases in angiotensinogen to angiotensin 1, increased blood pressure that inhibits the release of renin, and the expected with primary hypertension, but not in the findings, could also be associated with ischemic nephrons and the release of renin. We live in a high-stress society, and the effects of stress on an increased sympathetic nervous system activity causes things like increased vasoconstriction, increased heart rate, and an increased renin release. Insulin resistance and hyperinsulinemia. These are defects in glucose, insulin, and lipoprotein metabolisms that are common. The high insulin levels stimulate sympathetic nervous system activity and impair nitric oxide-mediated vasodilation. These can also have pivotal roles in vascular hypertrophy and the increased renal sodium absorption. In the case of endothelial dysfunction, prolonged vasoconstriction results in reduced vasodilation response, and this impaired response to the nitric oxide, which leads to further vasodilation. Be thinking about what manifestations of hypertension would you assess for in CS. Hypertension is often called a silent killer, as it's asymptomatic until severe and target organ disease occurs. While hypertension can wreak havoc on many parts of the body, the 4 major areas damaged are the brain, eyes, heart, and kidneys. Keep in mind that this damage goes very slowly. They may not realize that they have hypertension damaging and destroying their kidneys until it's far too late and that damage is already done. The symptoms of severe hypertension could also include fatigue, dizziness, palpitations, angina, and dyspnea. What complications will you assess CS for? And again, your first 4 areas to clue in on are going to be the brain, the eyes, the heart, and the kidneys. These target organ diseases occur most frequently within the heart, including the coronary artery disease, atherosclerosis, left ventricular hypertrophy, and heart failure. Also, the brain with cerebrovascular disease in the form of TIAs, strokes, and hypertensive encephalopathy. Here in figure 32-4 from the text, on the left we have a massively enlarged heart caused by hypertrophy to the muscle of the left ventricle. And this is compared to B with the thickness of a normal left ventricle. And as you can see, that hypertrophy greatly restricts the amount of blood the heart is able to fill with and pump effectively. In the case of peripheral vascular disease, atherosclerosis leads to PVT, aortic aneurysms, and aortic dissection. Could also be intermittent claudication, which we'll get into further in another chapter. Also kidneys with a nephrosclerosis leading to chronic kidney disease. And the eyes, damaging the retinas with a blurry or loss of vision, as well as retinal hemorrhage. CS is referred to his healthcare provider to follow up on his high blood pressure screenings. What diagnostic studies might you expect the healthcare provider to order for CS? When measuring the BP, we should order labs to identify or rule out secondary hypertension, evaluate target organ disease, determine the cardiovascular risk, and establish baselines before starting therapy. Ambulatory blood pressure monitoring avoids white coat hypertension. This non-invasive, fully automated system that measures the blood pressure at preset intervals over a 12 to 24-hour period. Teach patient to hold their arm still while the device reads the blood pressure and keep a diary of activities. CS's blood pressure is monitored for several visits and remains elevated. His serum cholesterol, BUN, and creatinine levels are also elevated. His creatinine clearance glomerular filtration rate is below normal and demonstrating renal insufficiency. What type of lifestyle modifications would you recommend to CS to control his blood pressure? And it's going to be the basics: weight reduction, exercise, dietary changes, stress reduction, and stopping smoking. The overall goals are to achieve and maintain a goal blood pressure, reduce the cardiovascular risk factors, and that target organ damage. These lifestyle modifications from the AHA Life Simple 7 include manage the BP, control cholesterol, reduce blood sugar, get active, eat better, lose weight, and stop smoking. For weight reduction, a weight loss of 1 kilogram will reduce the systolic blood pressure by 1 millimeter. Those caloric restrictions and physical activity can go a long way in bringing that blood pressure down to where we need it to be. Also, that DASH diet. This is fruits, vegetables, fat-free or low-fat milk and milk products, whole grains, fish, poultry, beans, seeds, and nuts. In the case of dietary sodium reduction, less than 2,300 milligrams a day is recommended for healthy adults, though less than 1,500 milligrams a day are recommended for those at higher risk. Moderation of alcohol intake is also highly recommended, with that being 2 drinks or less per day for men and 1 drink per day or less for females. In the case of physical activity, it's recommended moderate intensity aerobic activity combined with muscle strengthening activities, as well as flexibility and balance exercises. Avoiding tobacco products is also key, as nicotine causes vasoconstriction and an elevated blood pressure. Smoking cessation reduces risk factors within 1 year. In addition to lifestyle modifications, CS's healthcare provider prescribes hydrochlorothiazide. And this is done because the drug is a diuretic that will increase the amount of water excreted as urine. Decreasing the amount of fluid circulating in your bloodstream will work to decrease his blood pressure. The 2017 High Blood Pressure Clinical Practice Guidelines set the antihypertensive recommendations based on the patient's age, blood pressure, and other factors. The hypertension drug therapy has 2 primary actions: to either decrease the circulating blood volume or reduce the systemic vascular resistance. Adrenergic inhibiting agents decrease the sympathetic nervous system stimulation and work centrally on vasomotor center and peripherally to inhibit the release and block of adrenergic receptors on blood vessels. ACE inhibitors prevent conversion of angiotensin I to angiotensin II and reduce vasoconstriction and sodium, as well as water retention. In the case of calcium channel blockers, they increase sodium excretion and cause arterial vasodilation by preventing the movement of extracellular calcium into cells. There's also direct vasodilators that relax vascular smooth muscle and reduce systemic vascular resistance. Also diuretics, such as hydrochlorothiazide that we previously discussed. These reduce the plasma volume by increased sodium and water excretion and reduce vascular response to catecholamines. For a patient with hypertension, non-pharmacologic treatment plus one first-line pharmacologic drug. For a patient with stage 2 hypertension, non-pharmacologic therapy plus two antihypertensive drugs from two different classifications. If a drug is not tolerated, then another classification will be used. Monthly follow-up visits until the goal of blood pressure, and then at 3 to 6 months annually. Stage 2 hypertension or comorbidities could make these visits more frequent. For patient and caregiver education, report all side effects, including different medications that may be tried if severe or undesirable, and need to continue adherence to therapy. Common side effects include orthostatic hypotension, or feeling dizzy or faint when they change positions, such as standing up. Sexual problems can result in reduced libido or erectile dysfunction. In a lot of cases, men will, especially with beta blockers, just refuse to take them. You can also see symptoms such as dry mouth, where sugarless gum or candy may be recommended, and frequent voidings, which is why it's recommended that diuretics be taken early in the day to avoid them having to get up at night. In the case of resistant hypertension, this would be a failure to reach a goal blood pressure with appropriate therapy and a drug regimen, and can result in an increased risk for stroke or MIs. It could also be attributed to improper blood pressure measurement, volume overload, drug-induced or other causes, and secondary hypertension. The subjective data for functional health patterns include health perceptions, health management, family history, tobacco, alcohol, and sedentary lifestyles. Nutritional changes such as salt and fat intake, as well as weight gain or loss. Elimination, such as with nocturia, as well as activity, cognition, sexual and reproductive issues, and their coping and stress tolerance abilities. Other subjective data would include a past health history, including hypertension, cardiovascular, cerebrovascular, renal, and thyroid diseases, diabetes, pituitary disorders, obesity, and even menopause or hormone replacements. Objective data would be cardiovascular, such as blood pressure readings, orthostatic changes, abnormal heart sounds, pulses, or edema, as well as gastrointestinal, such as body measurements, neurologic mental status exams, and other diagnostic studies. In the case of primary prevention, this would be lifestyle changes, such as a DASH diet or decreased sodium. For individual patient evaluation and education would be screening programs, identifying risk factors for hypertension and coronary artery disease, blood pressure measurement, and drugs or other previous treatments. To get an accurate blood pressure measurement, there should be no smoking, exercise, or caffeine 30 minutes prior to the reading. They should rest quietly for 5 minutes, relax, with no talking, as well as proper size cuff placements, position the arm at the level of the heart, and use oscillatory methods. Deflate at 2 to 3 millimeters a second, and take in both arms, noting any differences. To assess for orthostatic hypotension, the blood pressure and heart rate should be measured after they're supine for 5 minutes. Assist the patient to standing and measure the blood pressure and heart rate at 1 minute and 3 minutes of position change. In the acute care setting, the blood pressure should be assessed with the vital signs, along with their volume status, the effects of drugs, and looking at the trends. Patients with persistent increased blood pressure should be evaluated for hypertension and referred to a follow-up. In the case of home blood pressure monitoring, you should use proper equipment and procedures, as well as have a set frequency for accurate recording and reporting. Unfortunately, patient adherence to this is a major problem, for reasons including inadequate teaching, low health literacy, unpleasant side effects of drugs, a return to a normal blood pressure so they stop taking it, as well as the high cost of drugs and a lack of insurance. Measures to enhance compliance include an individualized plan, active patient participation, select affordability of drugs, involving the caregivers, a combination of drugs, and patient teaching. For gerontologic considerations, hypertension has an increased incidence with age, with a 90% risk for those greater than age 55. It's also more likely to have white coat hypertension. These age-related physical changes are also due to a loss of elasticity in the arteries, increased collagen and stiffness in the myocardium, decreased adrenergic receptor sensitivity, and a decreased renal function. Elderly patients may also have altered drug absorption, metabolism, and excretion, often have a wide oscillatory gap within their measured blood pressure. We should be assessing for orthostatic hypotension, acute kidney injury, and other adverse effects very closely. A hypertensive crisis. This is a systolic blood pressure over 180 or a diastolic over 120. In this case, target organ damage is occurring and requires hospitalization. This is a very severe problem can result if prompt recognition and treatment is not obtained. Everything from encephalopathy, intracranial or subarachnoid hemorrhage, heart failures, MIs, renal failures, and dissecting aortas. For hypertensive urgency, more common, there's no evidence of target organ damage, and hospitalization is usually not required. It's associated with chronic stable disorders such as chronic heart failure, a prior MI, or CVA. Hypertensive crisis, on the other hand, has a history of hypertension, not adherent, or under-medicated. Other effects could be illicit drug use such as cocaine, methamphetamine, or PCP. Major signs could be hypertensive encephalopathy, which includes a headache, nausea, vomiting, seizures, confusion, coma, and retinal changes, along with renal insufficiency, cardiac decompensation, and aortic dissection, which would involve chest and back pain, with a reduced or absent peripheral pulses. For the hospitalization of a hypertensive emergency, our treatment is going to be related to the blood pressure and any evidence of target organ damage. This case, we're going to be focusing on IV drugs with a slow titration. And finally, we're going to monitor that cardiac and renal function closely. Frequent neurologic checks, place the patient on bed rest for those on IV drugs, and determine any underlying cause that we could find. These patients are going to be followed up with very closely due to the seriousness of the situation. But anyway, that's all we've got for this chapter. I'll see you in the next slide.